All right, so we've talked quite a lot about the immune system itself. So let's talk about some disorders of the immune system, ways that the immune system can go bad. And the first type of disorder of the immune system is what's called a hypersensitivity. This is where your immune system, basically responds to something that you don't want it to respond to, or responds in a way which is ultimately dangerous to yourself. So, immune system disorders fall into generally three categories. There's what are called hypersensitivities, which include allergies, transfusion and blood type reactions, transplant rejection, and overreaction to infection, things like toxic shock and stuff like that. The second is autoimmune diseases, where your immune system begins to attack itself, and this includes type 1 diabetes, lupus, Graves' disease, myasthenia gravis, multiple sclerosis, and a whole bunch of other conditions. And third is immune deficiency, where instead of your immune system misbehaving, it just doesn't do stuff at all. And, in either a subset of your immune system doesn't do stuff, or the entirety of your immune system doesn't do stuff. And in this lecture, I'm going to focus on hypersensitivities. So, there are four main types of hypersensitivities, conveniently named type 1, type 2, type 3, and type 4. In this lecture, I'm going to go over type 1 very extensively. This is the most common and well-known and best understood type. I'm going to go over type 2 in medium intensity. And then I'm going to sort of touch on type 3 and type 4. They are important, but they're somewhat less common and they're somewhat less well integrated with what and how we're talking about things. But type 1 hypersensitivities are what are known as IgE mediated hypersensitivities, because they are primarily based around the antibody IgE and its miseffects. These usually work through a histamine mechanism, and they can be either systemic or local. Type 2 is a cell lysis type of hyperimmune reaction, where cell lysis means that it's where your immune system is going to attack and destroy cells in your body that, at least in theory, you want to be a part of your body. The most common type of type 2 hypersensitivity is a blood type reaction, where you get some blood of the wrong type into your body, or you get your antibodies into someone else's body with a different blood type, and these two things do not mix well. Type 3 is what's called an immune complex reaction. This is where you get basically conglomerations of, or agglutinations of antibody antigens that begin to form large complexes that form blood clots and other disruptive things. And the type 4 is what is called cell-mediated hypersensitivities. This is the only one that doesn't rely on antibodies at all. It's mediated by T cells instead. It goes through the cell-mediated response. So, type 1 hypersensitivities are generally referred to as immediate, IgE mediated. Now, immediate doesn't necessarily mean right away. The reaction could take anywhere from minutes to hours to take effect, but it's always, pretty much always going to take effect within a 24-hour period if it's going to happen. In a type 1 hypersensitivity, what you have is IgE bound to mast cells or basophils. Now, if you recall from previous lectures, you'll know that IgE is has an antiparasitic effect. In general, that's what it's supposed to have. And you'll know that mast cells and basophils release histamine. And so this is going to be an inflammatory attack, and the inflammation is going to be mediated by histamine. So in this case, you produce IgE against a specific antigen, generally an antigen which is, while foreign, not dangerous. It's something that your immune system reacts to because it's not a part of your body, but it's usually, in at least a hypersensitivity, going to be something that is, not actually dangerous to you. It's like pollen or peanut protein or something like that. So type 1 hypersensitivities are not strictly inherited. If your father has a peanut allergy, that doesn't mean that you will inherit a peanut allergy from them. Even if both your parents have a peanut allergy, it doesn't necessarily mean that you will inherit it from them. But the tendency to have allergies, so the tendency to have type 1 reactions is inherited. If your parent has allergies, there is a higher likelihood that you will also have allergies, even if your allergies are not necessarily to the same thing that theirs were. Another thing about type 1 allergic responses is that they must be sensitized. If you recall, when we talked about the humoral response doesn't happen immediately, right? You have to have a B cell that binds to the antigen and becomes primed, and then you have to have a T cell that is activated by an antigen-presenting cell, and the T cell and the B cell have to hook up, and that leads to clonal expansion and selection. And since this is mediated by IgE, remember that the first class of antibodies made is actually IgM, and so you're not going to start making IgE until several days after you start making IgM. So in general, what this means is that you are exposed to the allergen. Let's say you're allergic to bees, or you have the possibility of being allergic to bee venom, right? You get stung by a bee. Bee venom goes into your body, And you don't have any sort of odd reaction to it because you don't have any IgE yet. But this bee venom is then like gonna be found by a B cell and internalized, and maybe it's eaten by a macrophage, or otherwise gets into something that can stimulate a helper T cell. And then the helper T cell and the B cell meet up, and you start making plasma cells, and those plasma cells are class switched to start making IgE. Like, this is now, a week or two after the bee stung you. The bee venom is long gone by this point, in all likelihood. All right? It was a discrete event. You got stung by a bee. You aren't getting stung by bees every day. So you got stung by a bee. You went, ouch. All this stuff then starts occurring over the next week. But by the time you start making IgE and they rush in to go fight off this, what they think is a parasitic worm, bee venom's gone. So you don't have any sort of reaction. But what happens is at this point, now your basophils have FC receptors for IgE on them. And so now the IgE is going to stick to the basophils like this and basically be used by the basophil as a receptor in the future. Now you are what we call sensitized. Now that you've been exposed to the bee venom, you have the antibody to it. That antibody is now bound to your basophils and your mast cells. And then the next time you get stung by a bee, do like this. So that's a bee sting. And you get some bee venom in there. Well, now the next time you are already sensitized, you already have the antibody, and you're going to start reacting right away. The bee venom gets bound to the IgE antibody on the basophil, and now the basophil is going to start pumping out histamine. And now you have an allergic reaction. Because what the allergic reaction is a massive release of histamine in response to the allergen. So type 1 hypersensitivities require sensitization, prior exposure, and it requires IgE production. And the IgE binds to the mast cells and basophils. And when something binds to the IgE, the allergen, it's going to stimulate them to produce histamine. So here we can see, your plasma cells. These are converted plasma cells that have been switched to making IgE. They attach to the mast cells. And then when inflammatory molecules, when the allergen binds to it, that causes a release of histamine through degranulation. And the result of this depends on whether you're stimulating basophils or mast cells, and whether this results in a systemic or localized infection, or response, I should say. In general, while both basophils and mast cells can be involved in this, mast cells are involved in your tissues near your barriers, and basophils are found in your blood. When mast cells release histamine, it results in localized inflammation to wherever the mast cells were, but the histamine is going to affect the local area and just the local area. Since basophils are in your blood, when they release histamine, it is going to get carried all over your body and affect everything in your body, leading to what's called a systemic response. Some types of responses that you could have could be hives, which is a localized area of skin inflammation. Hay fever, which is a localized respiratory inflammation resulting in increased mucus production and sensitivity of the nerves in that area. Asthma, which is localized sensitivity of bronchiolar muscle spasms, again in the respiratory system. And anaphylactic shock, which is a systemic inflammatory response resulting in lowered blood pressure, swelling across broad sections of the body, and possible death. So, as I said, type 1 hypersensitivities can be localized or systemic. So localized allergic reactions consist of hives, right? So here you can see some hives. These typically are patches of raised, inflamed areas, often, though not always, following what's called a wheel and flare motif, where you have like sort of a bump with like kind of lines of inflammation coming out from it. Hay fever is a inflammation usually of the respiratory tract. Now, when like your skin becomes inflamed and swollen, the fluid can't really escape because your skin is waterproof, so you end up with a bump. When your respiratory tract becomes inflamed, it's not waterproof, but the amount of blood and fluid going to the area determines how much mucus you produce. Like the more water you have, the more swelling you have in an area, the more mucus you will produce. So increased vascular permeability and increased blood flow to the area is going to produce more mucus, as well as more lacrimal secretions, tears. It's going to sensitize your nerves, which is going to result in more sneezing, right, as your nerves are sensitized to that. Could also result in itching, coughing. Your respiratory system is going to get irritated more easily. Both hives and hay fever, being localized inflammatory reactions, are blocked by antihistamines. You turn off the histamines, the inflammation goes down. Asthma is a little bit atypical. In asthma, what you have is the inflammatory mediators cause spasms in the bronchial tubes, causing them to close down, producing difficulty breathing. For whatever reason, antihistamines are not particularly effective against asthma, though steroids can be. But the most common treatment is actually to treat with a type, I think what's called an alpha blocker, I think. But you treat with something that's going to be a stimulant, because if you stimulate the sympathetic nervous system to the bronchioles, that's going to result in bronchiolar dilation, and that's going to force your bronchioles to be open and counteract the asthma. So for systemic reactions, the antigen enters the bloodstream and activates sensitized basophils. The basophils then release histamine, which spreads throughout the entire body. This is going to produce a full body inflammatory response. Large portions of your body are going to vasodilate, resulting in a loss of blood pressure. They're also going to undergo increased vascular permeability, evacuating water from your or fluid from your blood, reducing your blood volume, also resulting in lowered blood pressure and causing parts of your body to swell up, become puffy. This is particularly dangerous in the throat because your throat really has only one direction to swell, and that's closed. And so anaphylaxis can result in the throat swelling shut, difficulty breathing, and in severe cases can also result in shock, anaphylactic shock, where your blood pressure decreases to the point where you can no longer get blood to your brain. Either of these can be fatal conditions. Systemic anaphylaxis is generally treated in the short term with epinephrine, an EpiPen. And what that's going to do, epinephrine, is going to be a very, very powerful vasoconstrictor. So you're going to try to increase the blood, the blood pressure, get that blood back up to your brain. It's also going to counteract the effects of vascular permeability, basically squeezing fluid somewhat back into your blood vessels, and will help to counteract the swelling. But an EpiPen is a short-term treatment. It's not a cure, actually. And depending upon the severity of the allergic response, it's entirely possible that by the time the effects of the EpiPen wear off, you will still be suffering an allergic response. So it isn't as if like you can just go, bah, stab someone with an EpiPen, and then you're cool, they're good, they're saved. No, not necessarily. What an EpiPen does is buy you time. Maybe by the time the EpiPen wears off, they aren't suffering an allergic reaction anymore, but maybe they are. And if they're not in the hospital, they're going to start to die again. So you also have to get, for the medium term, you need to get patients to a medical care setting where they can be treated with antihistamines and steroids to basically suppress that immune response, make sure that when the EpiPen wears off, they aren't still dying. Depending upon the severity of the reaction, for a systemic reaction, antihistamines are also useful. They take a little bit longer to take effect. So it kind of depends on how fast acting a response is. Like a peanut, everyone's allergies are individual, but in general, a peanut or a bee sting allergy can result in like anaphylactic shock within minutes, and often that's not going to be fast enough, or that's not going to be give you enough time for an antihistamine like Benadryl to take effect. Like you're still going to be absorbing that through your stomach. Although there have been like cases of people who were taking Benadryl for like a cold or something like that, and they already had the Benadryl in their system when they were exposed to the allergen, and they had a much less serious response than they otherwise would have. But depending upon the amount of allergen that you're exposed to, you could have a relatively slow acting systemic allergy, something that takes maybe an hour before it starts to really kill you. And that might give enough time for an antihistamine like Benadryl to take effect. In any case, like, even if you have an EpiPen, having some antihistamine around in case you get exposed to your allergen is a very good idea. They're going to help to work with each other. So treatments to prevent allergic reactions. There are a number of different possibilities to treat allergies. So, as I said, in the short term, antihistamines work fairly well against against localized reactions, and EpiPen and antihistamines work to save your life against systemic reactions. But what about the long term? What if you're like, I don't know, like I have a good friend who was very seriously allergic to cats. I mean, it wasn't like she went into anaphylactic shock or whatever, but she was basically functionally unable to live with cats because she would like be suffering massive allergies the whole time. She loved cats. She had kids wanted cats. Well, how do you deal with this thing? There are a few ways that you can prevent allergies, or at least mitigate the effects of allergies long term. One is what's called desensitization. And this can be done, it's usually recommended to do under the instructions of your doctor or rheumatologist, but people have kind of jimmy-rigged their way through it before. But the idea here is that IgE isn't the only antibody that you make. It's not even the most common antibody that you make. So let's say that you've been sensitized to cat dander, right? So you've got your mast cells, and they have IgE coming off of them, right? So this is IgE. And so when you get cat dander in, you're going to release histamine. And start sneezing up all over the place, eyes tear up, really miserable. Okay. You're not going to be able to get rid of the IgE. You've got the IgE, that's probably going to continue. But what you can do is, by repeated small stimulations of your immune system, repeated exposure to the allergen, starting in small doses and then increasing, what you can do is train your system to produce a lot of IgG. So now you have a lot of free IgG. And when you are exposed to a cat, say, and you start making the cat, or you start getting the cat allergen inside, you have so much IgG that before it binds to your mast cells, it gets coated in IgG, which is a neutralizing antibody. Remember, we talked about the effects of antibodies. One of the things that they can do is neutralize, right? This is commonly used against viruses, where the antibodies bind against their spike proteins, and now their spike proteins are coated with the antibodies, so they can't bind to your cells. They can't get into your cells, and they're just harmless. They're neutralized. Same thing can happen with toxins, right? Well, the same thing can also happen with allergens. If you make so much IgG that the allergens get coated with antibodies before they can interact with your mast cells, well, once they're coated with antibodies, they can no longer interact with your mast cells, and you will have neutralized the allergen before it causes an allergic response, or at least before it causes a very severe one. And the way you do this is by repeated small exposure and that increases. So if you're doing this under a doctor's supervision, you might go in and get, like every week, get tiny injections of your allergen or tiny exposure to whatever your allergen is under a controlled setting where they expose exactly how much you're getting to it, and then it increases and increases and increases every week until eventually you have so much IgG that your body can tolerate exposure to that allergen, and you're going to neutralize it before it ever gets the mast cells. And in the case of my friend, what she did was, I mean, obviously she had lots and lots of friends who had cats. And so, she would start off, she would go to a friend's house for like 10 minutes every day for a week. That was like about as much as she could tolerate. And it was a friend who had cats, and she wouldn't like interact with the cat or anything. But then, the next week, she upped it to 15. The week after that, she upped it to 20 minutes and started petting the cats. And, after 6 months of this, she could live with cats. She still had some allergic response to them, but instead of being like a crippling response, it was just merely annoying and something she could tolerate. This is, like, if we're talking about a cat allergy where your eyes get watery and your nose gets stuffy, then you might feel free to sort of experiment on your own. If you have like a peanut allergy, I would very much not recommend doing this on your own, and definitely talk to your doctor about it, because a very little exposure to the peanut allergen could kill you with a systemic reaction. So you're going to want to be in a medical setting before you do anything like that. But some allergies just get desensitized over time naturally, and some don't. Another more drug-based possible treatment is what's called a RUMAB, which stands for recombinant humanized monoclonal antibody. This is basically what we do is we take a human and we inject them with, or actually we probably take an animal, and we inject them with this allergen until they make antibodies to it. And then we take their antibodies and we splice them. We splice the variable region into human genes so that now they're making human antibodies. And we take the binding fragment of that, and we teach bacteria usually how to make it. And then we make a whole bunch of it. And this is what's called a recombinant monoclonal antibody. And now we grow up a whole bunch of that, and you can give somebody injections of that if they know that they're going to be exposed to the allergen. And it basically does the same thing as the IgG, except instead of teaching your immune system to make its own IgG to neutralize the allergen, you're getting an antibody from somewhere else and injecting it into your veins. And then what that's going to do is that's going to neutralize the allergen before the allergen has time to interact with your mast cells or your basophils. That's a temporary thing, but it doesn't take quite so long to build up the tolerance. And desensitization is always a little bit tricky. Sometimes it works with some people, sometimes it doesn't. A RUMAB, because they're just giving you an injection of it, it's pretty much always going to work. But unless you're getting an injection of RUMAB like every couple of weeks, then you have to sort of know that you're likely to be exposed to the allergen ahead of time. All right, type 2 hypersensitivities, what are called cytotoxic, meaning that they destroy cells. And in this case, they usually deal with blood incompatibility or cell surface receptor incompatibility. And the most common type for this is like you get a transfusion of the wrong blood type. So let's say that you have blood type A, or this is the recipient. So you have blood type B, which means that all of your cells, they have the B antigen on it, and that means that you make antibodies to all of the antigens you don't have. You don't make antigens to B because you're type B, but you do make antigens or antibodies to type A. And if you get a transfusion of type A donor blood, your antibodies are then going to attack the type A donor blood and bind them together and destroy the cells. And that does more than just make the transfusion ineffective. When the blood starts to lyse, right, what it's going to do is create a bunch of agglutinated blood clots of lysed blood cells that are going to spill all of their content out. And so, in addition to just destroying that blood, you're also going to end up with a whole bunch of microclots floating around your system that can go and do serious amounts of damage. So it isn't just that the transfusion is going to be ineffective. The transfusion is going to actually be quite dangerous. And there's kind of two ways that this could happen, right? So if you have type B blood and you get a transfusion of type A blood or type AB, or if you're Rh negative and you get a transfusion of Rh positive, either way, then you're going to react against those cells and lyse those cells. The other possibility is if you get a transfusion of plasma from someone who has the antibody, right? Antibodies live in the plasma, and so if you just got a plasma transfusion from somebody who has anti-A antibody, then that is going to go and attack and destroy your type A blood. Because antibody, it's going to agglutinate. This is usually going to be mediated by IgM very strongly, because IgM is very, very good at agglutination, but also by IgG, which can activate the complement system against the blood cells, causing them to lyse. And so blood type incompatibility is most of the time we think of it happening with transfusions, but there is I don't want to say more tragic because it's all tragic, but there is a more difficult consideration to take as well, right? And that is incompatibility between the mother and fetus. This mostly happens with Rh factor. It can happen with the ABO blood types, but that's less common for reasons that I don't entirely understand. But it is well known and well documented with Rh factor incompatibility, right? So this is when you have an Rh negative mother and an Rh positive fetus. So, the fetus, right, and the mother's blood don't actually exchange. So, for the most part, on your first child, things work fine. The mother has Rh negative blood, but unless she has received a bad blood transfusion in the past, she probably does not make Rh positive antibodies because her immune system has never been sensitized to it. So she's not making Rh positive antibodies. she has a baby that has Rh positive blood, but we're cool because she doesn't make antibodies against it. She's not being exposed to the fetal blood at this point. However, during childbirth, turns out, kind of a bloody process. There is going to be some blood involved in that in all likelihood. And there is a good chance that some of the fetal blood will get mixed into the mother's blood during childbirth. And so her body will become exposed to the Rh positive cells, and now she's going to start making anti-Rh antibodies. So the next time she gets pregnant, so first pregnancy, fine, but sensitized. Second pregnancy, and again, second pregnancy with an Rh positive fetus. If you have an Rh negative fetus, you're fine. But the second pregnancy with an Rh positive fetus, well, now she makes anti-Rh antibodies. And if you recall, IgG can be shared across the placental barrier, providing some immune protection to the fetus. Well, if she makes anti-Rh antibodies and the fetus makes Rh positive blood, then her IgG attacks the fetal blood. And yeah, and that usually results in a miscarriage. Not awesome. There is a treatment for this, or kind of. It's more of a preventative, and it's called RhoGAM. RhoGAM is anti-Rh antibodies that you give to the mother, usually during the entire third trimester, just to be case. But certainly during labor and childbirth. And just like we talked about with desensitization and the RhuMabs on the previous page, what the RhoGAM does is any blood that does get into the mother's system, any fetal blood that does get into the mother's system, will be promptly surrounded and neutralized by the RhoGAM before her B cells can find it to start learning how to make antibodies against it. So in this case, you're using this artificial antibody to prevent her immune system from learning about the Rh positive blood. So she never starts making the anti-Rh antibody, and the next time she has she gets pregnant, she still doesn't make Rh antibody, and it's just the same as it was with the first pregnancy, and you don't have to worry about her antibodies attacking the fetus. Type 3 hypersensitivities. These are what are called immune complex mediated. They are mediated generally by IgG or IgM. And so this can happen with if you have an antigen that is in slight excess so usually when you form an agglutination, right, a whole bunch of antibodies gluing a whole bunch of pathogens or whatever together, it becomes very large, it falls out of solution, and your phagocytes come and clean it up very quickly. But at exactly the right ratio, you can end up with smaller agglutinations, basically very, very tiny clots that that remain soluble and can continue moving around your body. But they're still large enough that they can lodge in the smaller blood vessels, the capillaries, and do damage there, starting clotting cascades and activating the complement system at random points where they land inside of the body, causing and triggering internal bleeding and internal inflammatory events wherever they happen to land. And these are too small and too mobile for your phagocytes to easily catch them and clean them up until after they've done damage. Type 3 hypersensitivities can be allergies, but they can also be just a thing that happens as a result of an infection. Right? There are some pathogens that tend to activate this hypersensitivity response, and that's a part of how they do damage to you. But there are also some allergens that people have that also tend to activate this pathway. So this can occur during bacterial, viral, or protozoan infections. But it can also result from, if you know anyone who has a penicillin allergy, penicillin allergies usually work through this mechanism. What it does is it usually results in kind of internal inflammation as a result of these small complexes getting stuck in various parts of your body. So common symptoms are going to be rashes if they get stuck in your skin, joint pains if they get stuck in your joints, farmer's lung if it gets stuck in your lungs, sort of a chronic inflammatory response in the lungs. Lupus works through this mechanism, as well as several different bacterial infections, endocarditis, rubella, malaria, glomerulonephritis, which is a very potent kidney disease, all can do damage through this mechanism. What I mostly want you to know about this is that it is mediated by IgG or IgM, that it's caused by these immune complexes getting lodged in your tissues and causing clots and complement cascades. And I want you to know that penicillin allergies fall into this category. Here you can see sort of what's going on here, right? So if you have the proper mixture, the ratios have got to be right, of IgG and antigen, then they form these small complexes, and these complexes can get lodged in various places. So type 4 hypersensitivities. Last one. These are what are called delayed type cell mediated. So if you remember, the type 1 hypersensitivities were immediate response, and immediate doesn't necessarily mean immediate. It means within 24 hours. These are delayed type because their response usually peaks 2 to 3 days following exposure. This is not mediated by an antibody. It is called cell-mediated because it actually relies on the cell-mediated response, which involves cytotoxic T cells. And this is another cytotoxic response, meaning that what it's going to do is destroy your cells. It's going to kill cells rather than generate an inflammatory response or, it is going to generate an inflammatory response too, but it's not generating a histamine response, and it's not acting through antibodies. And the cell-mediated response is slower than the antibody response. That's why this is a delayed type reaction. The most common type 4 hypersensitivities are going to be skin contact things. So what's called contact dermatitis, which is when your skin reacts by making an itchy, scaly rash. Not necessarily like a wheel and flare motif, but an itchy, red, scaly rash due to long-term contact with things. So some examples that I'm going to want you to know about potential allergens for this are like metal responses. If you've ever had cheap jewelry that caused you to break out in a rash, that's usually a type 4 hypersensitivity. Latex allergies are usually a type 4 hypersensitivity. And poison ivy, poison oak allergies are usually a type 4 hypersensitivity. For this, what I want you to focus on knowing is that it is delayed, that it works through T cells rather than antibodies, and I definitely want you to know that it is typically contact dermatitis, and that metal jewelry, latex allergies, and poison ivy are examples of this. And here's just like an example of what's going on here. The inflammation is going to be mediated by cytokines released from helper T cells as a part of the cell-mediated response. And you will also get cellular damage from cytotoxic T cells activated in the area. All right, and that's what I have to say about hypersensitivity.